Sure.
Because I know you're UTHSCSA, but you have another role besides that name badge.
Well, I run the clinical side of the CTRC, which includes the Institute for Drug Development, and our faculty staff the cancer service here. So, for example, Cesar is Delicasso, who's head of the Hem-Onc service here, worked with me at the MD Anderson, hence is being persuaded to join us. So our connections are on many, many different levels. And recently, some of you may be aware with the CRADA process, there's now a little bit more transparency about which companies are working with the VA on phase 1s, etc. So we've been able to increase the number of phase 1 studies here quite significantly and anticipate doing so far more. I've been here about 3 years, and one of the areas that that has changed a lot, partially as a consequence of that, is the fact that I'm very interested in hematologic malignancies, and the AML, or acute myeloid leukemia, is what I want to focus on briefly with you, because as a matter of interest, on the 1st of September, 2 new drugs are before the FDA for elderly AML. And that's they are 2 of the only 3 that have ever gone up there. The first one was about 2 years ago and failed. And I wanted to give you the backdrop of, why are we so focused on this problem? The second is AML is, as you can see here, relatively rare. However, in part because of the mentality of people focused on it, and in part because of tissue access, what we learn in AML and allied disorders like myelodysplasia tends to spill out and benefit knowledge in cancer very, very quickly. And I'll give you some examples of that. This is the standard management, and it has unfortunately been standard for some decades now. When people come in, as those of you who take care of them know, with acute myeloid leukemia, they're usually very ill indeed. Multi-organ failure, anemic, thrombocytopenic. They may well have multiple infections. So apart from a rapidly proliferating malignancy and all the complications attendant on that, they have a failing immune system and a failing marrow. So that's a pretty toxic combination. We attempt frantically to get the disease under control, which involves reducing the leukemia clone, and to try in the process and restore some degree of normal hematopoiesis. Notice all the caveats. Try. Getting somebody into a remission is a necessary first step towards cure, but it is quite a long way from your average remission to telling a patient that they're cured. In fact, even when we get people into remission, the odds that we cure anybody is quite low. So post-remission therapy is vital. Around the world, for the younger patients and for those who are richer, stem cell transplantation may be an option. It's not an option for elderly patients, and I'm not really going to spend any more time on it. The latter point is one that here at the Cancer Centre we're very vested in, because leukemia, as I'll show you, is predominantly a disease of the elderly. We've more and more evidence of immune abnormalities in these patients that allow clones to develop and persist, whereas perhaps in younger patients they might be eliminated. So maintenance therapy and immune modulation is a very big part of what we see as the future therapy of this disease. To give you a quick idea of what do I mean by biology, all of our cancer therapy now is pretty dependent, as you know, on tight integration with pathology, cytogenetics, molecular biology, etc. And when I say tight integration, I mean we literally cannot start therapy on most of these patients without a pretty sophisticated molecular breakdown. To start at a fairly gross level, these are just cytogenetics. And you can see the difference between adverse and favourable in terms of, and these are younger patients, in terms of survival. As a matter of interest, intermediate risk includes normal. In other words, there are cytogenetic abnormalities that confer a good prognosis, which is rather bizarre. as none of them should be there. That's not what you'd expect. They almost never, the favourable risk cytogenetics almost never occur in the elderly, but it is interesting that there are tumour-specific abnormal karyotypes that confer a better than normal karyotype prognosis. The main reason that most of our patients die is failure of therapy. You might think a lot of it is due to loss because of bleeding, infection, etc. In point of fact, over the last decades, we've done very, very well there. And these are cumulative relapse rates, and they speak for themselves. So the great preponderance of eventual death in acute myeloid leukemia is failure to get the disease under control, not killing the patient in the attempt. And that is quite important. Now, when I say about molecular biology, this is just focused on the normal cytogenetics groups. So these are breakdowns of various cell surface, cytoplasmic, and nuclear factors, and combinations of those factors. And it will give you an idea how subdivided even the so-called normal karyotype population is. Why do we care about all this? Because we have individual therapeutic agents, for example, directed at FLT3 at that target. When you look at that breakdown, you'll see that FLT3, we care about whether it's a tandem duplication within the kinase, or whether it's internal tandem duplication or mutation. Even those nuances within an individual molecular marker have therapeutic relevance for us. So on a good day, I hope our molecular biology pathologists love us, and on a bad day, they probably have mixed feelings, because of course we want all these results yesterday. And as we have more and more specific therapeutic agents, the urgency to get this sort of subpopulation diagnosis out increases. Now, to get to the focus of today's discussion, we're doing very, very, very badly in older patients with AML. And I never really know what the right phrase is: elderly, older, and who says. In other words, the biology is far, far more important than any empiric chronologic cutoff. 60 years of age has become somewhat endorsed by the agency, the FDA, in terms of drug approvals, so you see a lot of breakdowns greater than over 60. But I need not remind this group that that's pretty artificial, and that you see people, because of comorbidities, etc., who in their 50s are far iller than people in their 70s or 80s, and that is an issue. Nonetheless, if you look here at a distinction on the youngish side, 55 above or below, you can see basically that over those decades we did have a significant improvement in the younger patients, largely due to the introduction of cytarabine and learning how to use it, which took quite some time. Whereas in the elderly people, on the right as you look at it, you see precious little improvement once cytarabine was introduced. And obviously those curves haunt us, because it's a bit like adult ALL versus pediatric ALL. No matter how many times you say it's a different disease, the fact that you can cure the majority of one population and fail abysmally in the majority of the others constantly keeps you going. It's not as if you're chasing something theoretical or ephemeral. It's pretty clear on the curves on the left here. You can cure far more of those patients if you could figure out how. Now, this is a bit of a silent disgrace, really, in the sense that while I see it all the time in cancer care in general, in leukemia in particular, you see a very heavy bias against the elderly. And it's very interesting how multifactorial it is. Objectively, if you chase the money, which is the best way to find out this information, most patients over 60 years of age in the United States get offered neither hospice nor any specific care for AML when it's diagnosed. Relatives may be given some vague diagnosis. Quite often the patients are not told actually what's wrong with them. So you've got this very large majority of patients who are out there who are getting no therapy or poor therapy. And that population is about 2/3 of the overall population with AML. So the missingness is enormous. The 5-year survival in those who are treated is less than 10%. So bear in mind this tends to perpetuate itself. If you treat very few and you treat most of those off protocol, you perceive the therapy as hopeless, so you don't offer it to the next patient, and round it goes. Why does this happen? Our current therapies fail, as you've seen. The patients tolerate chemotherapy poorly, so there's an immediate negative feedback for the treaters. More comorbidity, which I'll get to. But most importantly, there's the sort of bullying that goes on locally with CareLink, for example, and globally with insurance, which basically makes it difficult for older patients to get on. If you give them enough paperwork and they're frightened enough, the odds are at some stage they will, stop the process. It really is quite frightening, the number of barriers that are put in the way of the elderly getting on studies, etc. And it takes quite a bit of pushback to deal with it. When I say the standard therapy is failing, I showed you some curves there from a large cooperative group earlier. These are curves generated at the MD Anderson when I was there. And we tried quite a number of variations on the standard therapy for younger patients, and they all failed too, just to make it clear, as you see on the right-hand panel. So really what we need, bottom line, are new drugs for these patients. Some years ago, I was visiting Yale, and there was a gentleman there who had spent most of his life learning how alkylators worked and how to design them and how to optimize them. And alkylators, as you know, are a broad class of DNA poisons that have served us well. They have a bit of a dubious history and came to us from nitrogen mustard gas use in the wars. So they came by a rather evil route, but having been refined, have, as you know, become very, very effective anti-cancer agents. Melphalan you'd be quite familiar with, for example. So Dr. Sartorelli had an aim in mind, and I must confess at the time he was probably one of the few who understood the aim. And he wanted to design a specific alkylator that did two things. It would generate an alkylating species, which is the DNA damaging species. It would bind to one specific point on the DNA, which is the O6 position on guanine. The reason he wanted to put the alkylating species specifically there is they had worked out that you and I have an enzyme whose main job it is to protect that point. In other words, if you and I environmentally or deliberately are exposed to DNA damage there by putting an alkylating species on, we have an enzyme that's specifically designed to go in and take off that alkylating species before the DNA is actually broken, which is pretty fascinating. So at some stage in evolution we were exposed to a threat specifically to that position, and we evolved to deal with it. So the point being that you have got, if you could generate a drug, which is what he was trying to do, it would simultaneously generate an alkylating species and also generate another moiety that would inhibit this enzyme, then you would not alone be able to target O6, but you'd be able to inhibit the enzyme that could pull that species away before you damage the DNA, which was a very, very, very clever and ambitious project. And what I wanted to share with you briefly is how tenacious, I guess, you have to be to get a drug before the FDA, which, as you all know, is a long way from approval. Much of the literal propaganda that we are exposed to, particularly in the current healthcare debate about pharma, really trivializes how difficult this is, how expensive it is, how long it takes, how many mistakes you make, how long it takes to recover from them, etc. So I want to go through these series of phase 1, phase 2 and one phase 3 study that basically has led up to the September presentation. And what hopefully we'll find interesting is most of it is focused on older patients. So this was a typical phase 1 that we did with this drug. Smallish number of patients, less than 40. Younger, but patients up to 85 years of age. Start out with a range of doses, and as you know, the purpose in a phase 1 is to try and find what's the toxicity profile of the drug. Unlike in most other scenarios, we were delighted that this drug we could give up to doses that caused pancytopenia. Normally, if you're developing a drug for patients with breast or ovarian or any other solid tumour, once you begin to see myelosuppression, you back away. In leukemia, we do the opposite. We're interested to see how myelosuppressive can a drug be while being relatively non-toxic to other organs outside the marrow. We rarely see remissions on a phase 1. By definition, these are patients who failed multiple prior therapies. And we were very pleased to see a couple of complete responses in patients on that phase 1 that had very, very refractory disease. Also, we were very encouraged to see this pattern of toxicity that you see here. Notice that most of the adverse events were in the marrow, thrombocytopenia, pancytopenia. Here we're looking at grade 3, 4, in other words, the more serious adverse events. And you can see that outside the bone marrow on that phase 1, there's precious little. You're not seeing major damage. And you might say, well, what would you expect to see on an alkylating drug given at these very, very high doses? You might see bladder bleeding. That's fairly typical of some of these drugs. You might see lung damage. You might see some neuropathies. None of those were evident on that phase 1 study. So then you take the drug forward and you decide, coming out of the phase 1, well, this is clearly a powerful drug. We got CRs. Clearly we can manage the toxicity. Most of it is within the bone marrow. Where are we going to go next? So the first thing we did is go to the worst possible population. And they are people who have got a remission, but it's lasted less than 12 months. Now, in fact, that could mean technically somebody who never got a remission, and quite often does. So literally from 0 to, let's say, almost 12 months remission duration. And here you see the survival curves, and you're going to see a lot of these in rapid succession, so your eyes are not deceiving you. This is 50% of the patients dead at 6 months, and almost nobody alive beyond a year. It is literally as it looks. So it's diabolical. And this was about 200 patients that we'd given a high-dose RSC, which is a pretty standard relapse regimen, or any of a variety of investigational therapies, and you can see that it made no difference what we did. Cloretazine did not improve matters. And here's the survival curve of 54 patients with very early or no remissions who got cloretazine compared to over 230 others in the control group, and there was no difference. So as a single agent, the concept of giving it to patients greatly at risk, we abandoned. So then we said, well, as a single agent, either we move it frontline, because waiting until patients have failed does not seem prudent, or we combine it with other drugs. Cytarabine, as I mentioned, is the drug perhaps above all in the last few decades that has changed the prognosis for patients with AML. So the most logical first drug to combine cloretazine with was RSC, and that's what we did. This was a very, very interesting study, and one in which, in retrospect, which is always, of course, a great luxury, we clearly made a mistake, although it's not yet clear to me what it was, but I'll show you what I mean. So this is a phase 1 study. You're taking standard doses of cytarabine and you're combining varying doses of the alkylator. And to our surprise, we got the dose of cloretazine pretty well up to where it was with the single agent. In other words, we were able to add the second drug without an enormous increase in toxicity. The dose-limiting toxicity now was both myelosuppression and colitis. And the colitis clearly was not happening because of the cloretazine and was a gift of the cytarabine, which is what we'd expect. To our amazement, in 31 patients above a certain threshold dose, 10 of those patients, or almost a third, got a remission. And all of these were patients who had failed cytarabine in the recent past. So pretty clearly the second drug was able to achieve something pretty significant in combination. The second thing that was very encouraging about that study was there really was a relatively clear correlation between the amount of the defense enzyme, so to speak, you had in the blasts and whether or not you got a remission. So if you had blasts where there was a very high level of the enzyme, you tended not to get a remission. If there were blasts or leukemia cells in which there was precious little of the enzyme, and the alkylating species was likely to be left alone to do its damage with a much greater chance of response. And those sort of biomarkers, as you know, are quite important for us. In terms of toxicities, nothing new emerged. Marrow toxicity, colon, typhlitis, enteritis, etc. You'd expect to see that with cytarabine. But please notice again, there's no lung toxicity here. There's no drama outside of a few restricted organs, and overall, very, very little overall toxicity. That meant that we decided to go ahead and propose this very large study to the FDA. And this was a study in first relapse patients in which we were going to randomize the patients to receive cytarabine with or without chlorotazine. The idea was to do it internationally, 420 patients, 2-to-1 randomization between the chlorotazine RSE and the RSE control, almost 70 sites, and to do this in 24 months. Went to the FDA and got what's called a special protocol assessment, which is where you basically reach an agreement with the agency on the minutiae of the design of your study, and it's quite an important basic step towards approval. The DSMB, the Data Safety Monitoring Board, asked us to hold the study at 177 patients on the combination arm and 86 on the control. We had got a very refractory patient population. In other words, as you saw earlier, this was open to people whose remissions could have been between 3 months and 24. The median duration we got was 10, so below 12. These are very refractory. And at that stage, the study was put on hold. And the reason it was put on hold was because of an imbalance between the responses and deaths. The good news you see illustrated here, and that was that the chlorotazine was increasing the RSE alone response rate from 19% to 35%, which is obviously an extremely significant elevation and improvement in response rates. And this pretty well pertained to all of the subsets of patients. The main ways in which we divided them up were in terms of age, younger and over 60, and CR duration, less than 12 months or over. So very, very, very good news on responses. Not so good on deaths. So the early death rate, and that is within 30 days of start of therapy, was 11% on the combination, 2% on the placebo arm. Now, this is more complicated than it might appear, because early deaths, the reason we talk about early deaths and not what was drug attributable, for example, which you might hear in other presentations, is quite a lot of early deaths are progressive leukemia. In other words, it's failure. So in the early days, in particular, we cannot distinguish between deaths from the leukemia or deaths from side effects of therapy. But anyway, however you subdivide these death rates, it clearly was higher with the combination than cytarabine alone. Most of the deaths were infectious, but for the first time you see here respiratory. And that was surprising, because we had expected and looked for respiratory deaths from the time the study began. The drug development began, I should say, because that's what you expect with an alkylator. Melphalan, busulfan and the like are not kind to lungs. So we'd always been expecting to see some respiratory toxicity, yet we did not see it until we combined this drug with cytarabine, which we were not expecting. The overall degrees of myelosuppression, overall survival, etc. between the two arms were equivalent. So we had not done the population any harm, but the problem was what should have translated into a very significant gain in terms of getting more CRs, we were losing because of myelosuppression deaths predominantly. So back to a very detailed analysis. DSMB approved or recommended reopening the study. We then got an independent audit, then went back to the FDA, and now the study is reopening, but with lower doses of chlorotazine, which is logical because you'll have less myelosuppression. Interestingly enough, the FDA wanted the inclusion of recombinant growth factors, which frankly it's hard to see in retrospect what the justification for that was, because the growth factor use between the two arms did not appear significantly different. In other words, the growth factors did not appear to have helped on the original study. So there you have a phase 1 of the single drug, a phase 1 of the drug in combination with RSE, and a phase 3 of the drug with RSE versus cytarabine alone. And in terms of relapsed patients, we're now going to have to wait for the reopened randomized study to see what are we achieving and what are we not. But now we get to the bit that's specifically focused on elderly patients. If you looked overall at this drug, the impression you get is very powerful. If you push it too hard, you'll get too much marrow toxicity and you will kill people. But there is a dose range within which you may be able to give this drug to people that you could not give, say, daunorubicin or anthracyclines to today. So this is the first of 2 studies. This one we took the previously established single agent dose, 600 milligrams, gave it to over 104 patients that were previously untreated. So these were very high risk patients, and all of them had to be over 60, which was the first time we had done this. As you can see, the median age 72, ranging up to 84 years of age. Half of these patients had a prior myelodysplastic syndrome or prior therapy for a solid tumour, so very high risk, and half of them had intermediate or poor cytogenetics. So one way or the other, by age and by biology, very high risk disease. And the response rates were really very, very pleasing. In fact, 22 of 44 patients with de novo AML, in other words those that did not have an antecedent overt hematologic disorder, got a complete response. Now, considering by definition that we picked people who would not normally be treated at all, this really was exceptional. Then we began to look at, well, in the poor performance patients, if you really keep pushing it, in those with a performance of 2, status score, of 2, did the CR rate hold? And the answer is yes, it did hold. Then you start pushing it more. Well, let's move it up to 70 years of age, and let's look specifically at people who have performance score 2s, and you see the CR holding. Now, for those of you who have an interest in, older patients or the whole discipline, even those of us out there taking care of cancer or doing a lot of phase 1 development that you think might not pay a lot of attention to this literature or whatever, I hope I'm convincing you that we do. Because we really do keep analysing it to see, do we or do we not have drugs or a regimen that is particularly useful in older patients. Here's the toxicity. Again, please bear in mind these are all patients over 60. This is only grade 3-4. And these are people who are selected for poor prognosis. And if you scan down the list, you see 2 things. Overall, very little toxicity, no appearance of pulmonary toxicity. So as a single agent, we're not doing any damage to the lungs. If you look at the primary causes of death, there's 2 things I want to draw your attention. Overall, it's 17%. To put that in perspective for you, in younger patients, it's frequently about 20. And in older patients, those few who are treated, it's usually as high as 60, 60. In other words, the early death rate, even among those who are treated, is phenomenally high. Here you have a deliberate choosing of over 100 patients with high risk. You're getting a CR in about 30% of them and an early death rate of 17%. And as you can see there, if you look at the primary causes of death in those 18 patients, you have 5 where investigators said it's the leukemia. You have another 8 with infection where it's difficult to tell, and pretty impossible to tell with multi-organ failure. Now the 2 with respiratory failure are interesting because you could say, well, that may have been significantly contributed to by the drug, and indeed it may. But don't forget, a good fulminant pneumonia will give you respiratory failure, etc., etc. So it is difficult. That's why we stick to the objective death rate within 30 days. So 17%, which of course is unsatisfactory, particularly if you're one of the 17%. But if you look globally at what's seen in this context, that is a very competitive, so to speak, early death rate. So then the question comes to, what's become known in our world as the pornography attitude. What I mean by that is I said to you at the start that 3 drugs have been developed for older patients with leukemia, and one of them went to the FDA and failed. And the reason in part it failed, we think, is because of the pornography approach, by which I mean we know it when we see it. In other words, what the investigators in the company said is, these people were unfit for standard chemotherapy, we wouldn't give it to them, and we gave them this new drug and good things happened, right? And the agency said, well, we don't believe you. We think they could have got, other drugs. And frankly, to anybody doing it, it was pretty manifestly clear that they couldn't, and that the investigators and the company were right, but it didn't matter. This attitude of, I know it when I see it and you must believe me, did not fly. And of course, the critical thing that's very difficult to convey objectively to another person, as you will all know very well, is comorbidity. Because we're in a difficult situation here. It's one thing to measure and interpret comorbidity in the context of, therapy for CVA or a myocardial infarction or whatever. But you're not going to give those patients anthracyclines, which may convert a modestly critical lesion to a very critical lesion. And somebody who is 70 or 80 at home doing fine, without any cardiac complaints, may have, gross cardiac failure after a tincture of anthracycline. In other words, we give a lot of potentially cytotoxic and toxic therapy to patients when they come in. So comorbidity is a very vulnerable area for us. In trying to see how to deal with this, there were a group, or is a group, in Seattle, in the Fred Hutch, where they have an enormous transplant program. And Mohammed Sarar and his colleagues had done a very interesting update, if you wish, or adaptation of the Charlson Comorbidity Index for patients getting transplant. And this caught my attention because, by definition, most of the patients getting transplant were getting transplanted for leukemia. So there was some degree of overlap. And basically what he and his colleagues had done is very elegantly modified this score to redefine some conditions, reassign weights to some conditions, and added and validated conditions that are quite important. To give you an example of when psychiatric, that's a term, but if you're sitting in a room in my clinic this afternoon and there's a new patient with acute myeloid leukemia there, before I know a thing about the chart or any of their tests, I can tell you right now that if they walk in on their own, as distinct from having a family member, they're going to do worse. For obvious reasons. This, as you've gathered, is incredibly complex long-term therapy if you're lucky. And if you're going to attempt that as an elderly patient on your own, then the challenges are that much greater. So psychiatric, social, whatever you call them, and these are of course quite distinct, the whole infrastructure is very important. So the Fred Hutch provided us with this scoring system, and then the question was, well, okay, if I take this scoring system and I apply it in retrospect to patients, the minority, the tiny minority of patients, currently given standard therapy, will it have any predictive value? So we went back and did that in 177 patients who had got standard AML induction therapy. You can see what happened. It actually was extremely useful and highly predictive. So if you had a very high number of risk factors, your early death rate was 29%. If you had none, it was 3%. So this attempt at quantifying comorbidity not alone was predictive in terms of early deaths, but actually was quite predictive in terms of overall survival. Now this is retrospective, and it has its flaws. In other words, if you're developing a comorbidity score for transplant patients, you'll have time to do proper lung function tests. If it's Friday evening and somebody comes in bleeding and needs AML induction therapy, you're not going to get, nor have you time to get, lung function tests. So you don't have, there's more missingness on AML patients for a given set of comorbidity criteria than there would be in elective processes such as transplant. However, having established that in retrospect this comorbidity score worked, we now retrospectively, applied it to this study. And here you see the results. And what we were interested in is all of the patients were over 60, as you heard by definition. Would the complete response rate hold as their comorbidity got worse? And you see that it did. So yes, people with no comorbidity, the higher CR rate, but people with 1, 2 or 3 or more factors, it was 32, 22 and 34. So we were not losing the response rate in people who had a lot of comorbidity. The early death rate was not climbing, and that was obviously very important. In other words, if we were getting a lot more remissions in people with a high comorbidity score, but they were all dying, that would not exactly be an achievement. So we took all of that back to the FDA and said, fine, you've now seen these data over the last 3 years. Can we reach an agreement that gets us out of the pornography issue? These are patients where we cannot do a randomized study by definition. There is no standard of care. Most of them get no treatment, so no randomized study is possible. How can we reach and do a single arm study where we define prospectively that these patients' risk is so high they cannot get any other therapies? So we did reach that, and what you see here is so the patients on this pivotal study had to be 60 or over, and then they had to have one more point to make them acceptable to the agency as unfit for standard therapy. If they were over 70 or more, that was acceptable in and of itself. If they had an adverse karyotype, in other words, if they had a poor prognosis cytogenetics as distinct from intermediate, if they had a performance score of 2 or above, and if they had pulmonary, cardiac or hepatic dysfunction defined as per that score, then they would agree that these were points that really mitigated against any current effective therapy being offered or being successful. This is what happened on that study and why the agency have agreed to review it. As you can see here, the death, grade 3, 4 adverse events, infection you'd expect, constitutional symptoms you'd expect, non-infectious pulmonary for the first time appearing. Now, prior information always affects what people see. By the time these adverse events were being reported, people were aware of the fact that on the chloretazine plus RC versus RC study, there was an increase in potential pulmonary toxicity. Perhaps that's why you see it here for the first time with the single agent, but it does appear as a potential toxicity. And here are the response rates on that second study. And you see them breaking down here by age, performance status, unfavorable cytogenetics, pulmonary dysfunction or cardiac dysfunction. And please notice that the CR rate is pretty constant throughout. What's particularly interesting, for example, is this is a drug known to have pulmonary toxicity, and yet those who went on with severe pulmonary comorbidity, you're retaining the same response rate as the overall population. So even in those that you would consider at highest risk of direct pulmonary toxicity or adverse consequences, you're maintaining the CR rate. If you look at the comorbidity status of the patients and you say, well, as that deteriorated, did the response rates and early death rates hold? This is what you see. The response rates and the death was higher and the death rate lower in the better shaped patients. But quite remarkably, in those with 3 or more factors on the comorbidity index, you still had a 30% CR rate and a 17% early death rate. Anything below 20, we really are doing way, way better in terms of early death rates than we were. So that data is in essence what is in front of, or will be in front of, or is in front of the FDA, but will be publicly reviewed on September 1st. The odds of an approval are very slim indeed. The agency is inherently biased against non-randomized studies, even when randomized studies cannot be performed, as is the case here, which is a bit of a frustrating conundrum, but that's the way it is. It is particularly frustrating here because in the elderly patients, randomized studies are not possible. And to show you one of the reasons why I say that, in elderly patients, one of the regimens du jour that's offered as palliation is low-dose cytarabine. And the Medical Research Council in Britain did an enormous study, 1,485 patients. And they basically had an intensive arm, a non-intensive arm, and if you, the physician, didn't know, you could randomize the patient to one or the other. So it is of interest to note that only 8 patients out of 1,485 were randomized. In other words, rightly or wrongly, the physicians looked at the other, whatever it is, 1,477, and said, I know whether this patient belongs in the high-risk category or the low-risk category. Now, whether that suits the regulatory authorities or not, it is pretty clear that leukemia physicians think they know whether people are fit for intensive or non-intensive, and they're probably right. So we have no prospective and criteria to define unfit other than what I've shown you in terms of the application of the comorbidity score. If you go back and you look at the randomized part of that MRC study, there were 103 patients randomized to low-dose RSE and another 100 got Hydrea. We would consider these palliative regimens. The early death rate was 26%, and this underpins the fact that even where you give very innocuous therapy, you have a very high death rate from the leukemia itself. In fact, almost 40% of the patients were dead at 8 weeks. So that is the early mortality if you cannot control the leukemia. The CR rate was 18% in favour of the RSE versus 1 in the Hydrea. CR in these elderly patients was very heavily correlated with survival. But it's the bottom line that's the most important in the context of what I've just discussed. Not a single complete remission was achieved by cytarabine in people with adverse cytogenetics or poor performance status. Not one. So if you want to go back and just to remind you, for example on this slide, you see comparable data there. So on unfavourable cytogenetics, 1 in 5 getting a CR. In people with high performance scores, 31%. Now, and that they are, on the cloretazine study, they are people who had the additional comorbidity burden that was not demanded of these patients. So that's really the backdrop of what it takes. If I just go backward to the summary slide, I suppose the main point I want to convey is that there are many of us out there who are not formally operating in elderly medicine, so to speak, who are extremely focused on this population, are very, very well aware of the biases against them in terms of trial participation, insurance companies, etc., which are very high, and are trying to develop agents specifically for them. We're continuously locked into a regulatory dilemma, which is if you deliberately go after an elderly population in which there is no effective standard of care, or most people are getting nothing, as I've shown you, how do you generate a randomized study? It would be unethical to, if you have a drug with any reasonable activity. On the other hand, if the regulatory agencies continue their emphasis on randomized studies, we're locked in a loop of intense difficulty in getting novel agents approved. And I would not be surprised, there's another drug on September 1st called clofarabine, that we developed in parallel with this. It's somewhat similar to RSE, followed a very similar development path, a little less structured, a little less disciplined, and they already have an approval for pediatric ALL. And we're a little more blasé because they already had an approval, but both drugs are up on the same day. And my fear is that neither will get approved because of these issues. And we basically have to find or contrive some randomized study. But to give you an example, the randomized study that would probably be the most popular would be cloretazine versus low-dose RSE. And you have to ask yourself, if you were at a bedside or in the clinic consenting somebody and you wanted to randomize them to a control arm that had been shown in a very large prior study to have 0 chance of a complete remission, whether that's a reasonable thing to do or not. So there's a very different level of reality testing between a regulatory agency and clinicians And this is a pretty cogent example of that difference, which just so happens to affect an elderly population, and hence me being here today and interrupting your lunch. I should say that all of this takes enormous collaboration at the preclinical, translational and clinical levels, and these are the various institutions and principal investigators that I guess I've spent most of the time working on with this agent. Now your handout has a much larger number of slides. I thought this actually started at noon, which is my fault. But anyway, the other slides will give you some information about 4 or 5 other drugs that we're very interested in pursuing, and all of them have a specific aspect that is tailored towards elderly people with AML, hence their inclusion in the packet. So, thank you very much, and happy to answer any questions I can.
So the good word is not to get it when you get older, not to get cancer.
Well, you know, but that's actually is a very interesting comment, because the more we develop targeted non-cytotoxic therapies for other malignancies, the less of this you see. As you saw on one of those slides, half of the patients had antecedent hematologic disorders, and most of that was a gift from prior chemotherapy. As we move towards more targeted drugs for the first malignancies, I would hope that we would do, which is the most satisfying thing to do, and that is prevent this thing happening in the first place. You're absolutely right. And if you look towards the end of that slide set, most of the drugs that are there are not peculiar to AML. They're applicable to solid tumours also, and none of them are cytotoxics.
What is the date on those? It will go to the...
September 1st.
Oh.
But it's, I don't know how many of you follow these things closely, but it is very, it's quite frustrating to go in and, you know, hear people say, well, we need a randomized study, and you keep thinking, well, we need world peace, and we need no global warming, we need a lot of things. But this is where we are, and this is what we have, and this is what's possible. And simply reiterating over and over again the perfect world doesn't really help the next AML patient on September the 2nd. You know, it's a big clash between, and it's getting more complicated because, of course, these drugs are expensive, so there is a political agenda to delay them as long as possible. You might not experience that as much here, but I'm very familiar with it in Europe, where it's pretty blatant. Well, it's clearly stated, it's not a matter of opinion. So, luck is right. I think the chances that either or both of these drugs will get through is pretty slim. And that is very unfortunate, because if you have a disorder in which most people are elderly, most of those get offered no therapy at all, because current therapies are perceived and known to be futile. And then you say, I want a randomized study, it's inherently, you know, physicians are not going to come along and take a 70-year-old with adverse cytogenetics and advocate to he or she that they be randomized to a therapy that has a 0 chance of getting a response. That's the reality of what we face. And I think it's important, you know, here, it's important that people realize this, because, you know, some of what you see in the press or some of these decisions all sound terribly erudite and thoughtful and conservative, and therefore correct. You know, I'm not sure that the older people with leukemia today who can't get conventional therapy would agree. But of course they're too sick to be at ODAC.
Unless they have families to advocate for them.
Well, you can do a certain amount of that, and, you know, it is interesting. I mean, the first drug that was up there really did a lot of damage. You know, if your first patient advocate or patient who comes up to advocate for a drug for the unfit elderly describes getting his first symptoms on the tennis court, you're off to a sticky start. So there's no situation that can't be made worse by stupidity. And that certainly is a factor, or has been. So hopefully you won't see any of that on September the 1st. As you say, people who were, you know, the FDA were saying, did you really mean to put somebody on who was on oxygen? And you think, you know, that's what we agreed with you we were going to do. Yes, we did mean to put people on with oxygen. It's not the usual situation where that would be a protocol violation. They're specifically who we wanted to put on protocol. You know, this is, as you know, we have a very large phase 1 unit here, the largest in the world actually, and one that has been involved with more FDA approvals of cancer drugs than any other. And it is a complex and frustrating business at times. And the more people, I'm very grateful for this opportunity, because the more people who know we do it and what goes into it, the nurses, the PAs, the regulatory people, it's quite a sophisticated operation to keep going with a very high failure rate. So you really need motivated people who are capable of taking the occasional success and running with it a long way. And we're lucky to have those people here. And as I said at the start, the VA, thanks to this CRADA mechanism, it is much more transparent now who can and will support phase 1 studies here. And we are getting far more of them open, which is good.
This is the crew that came up to make that happen.
Yeah.
Right?
Well, thank you. My dad had AML. He passed away. So I thank you
I'm sorry
for
to hear that.
yeah.
How old was he?
He had actually got an allogeneic bone marrow.
Okay.
But then it came back, and then they gave him the ARC.
I'm sorry to hear that. But we are trying.
Yeah.
And with your help, I mean, for all of my caution about what might happen, the mere publicity of having 2 drugs on the same day for older patients in a disorder in which there's no currently approved drug, that begins to generate a momentum. The patients and the families will pay attention. And we will get there. We will get one or both of these approved, and you can see for yourself they can potentially help. The most important thing is when you're in the middle of a busy day and there's 1,000 other demands, is do think about the protocols. They're all like tiny little droplets that feed into a very big thing in the end. So thank you very, very much.
Thank you. Dr. Giles came at very short notice. I saw his name in the Grand Rounds for Medicine and thought this would be a great title for you. And thank you, Dr. Giles.
Well, look, I
Your
didn't get
lunch.